Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy to have you here. It is, I guess I'm a little nostalgic a bit. This is the third March that we've been around. It's amazing that this has gone on so long. We're so happy that you have chosen to spend some time with us and we hope that we are of some value to you. Today, we are going to talk about oral health issues, which we don't talk enough about, and we're going to try to do better about that. And without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone. Thank you again for joining us. Hello, Dr. Barbara Neighbor-Stephens, Dr. Ivan Walks, and Dr. Hines, my esteemed co-moderators. As we go through this, I want to remind Dr. Coombs III that I was a department head at the Howard University College of Dentistry back in the day. And I used to know what a rubber dam was. I don't know if I can define that anymore. But I had the pleasure of being involved with a lot of the top dentists in the country. And I'm keenly aware that we don't pay enough attention to the effect on the entire body, on our health in general, of your oral health. It is not just something cosmetic, but something that's intimately concerned with every part of your health and life, and especially your cardiovascular health. So I'm going to ask Dr. Neighbor-Stephens to introduce our esteemed guest today, and even put a little humor in her relationship to the Coombs family, which is quite distinguished in medicine. And I do believe there's even a relationship with the New England Journal of Medicine from Dr. Alice Coombs. Go ahead, Dr. Neighbor-Stephens.
All right. Well, it is my pleasure to present our guest speaker today, who is Dr. Albert A. Coombs III, who is a doctor of dental medicine, a graduate of my alma mater as well. Well, we both went to affiliates of Tufts. He is a graduate of Tufts School of Dentistry and grew up in the Boston area and has been in practice now in the Washington area for several years. And as Dr. Maxey stated and took the fire out of what I was going to say, he is the distinguished son of one of our treasured medical advisory board members and my good friend, Dr. Alice Coombs. So without further ado, we will turn it over to Dr. Coombs to educate us on the importance of minding our oral health.
Good afternoon, everyone. Give me a moment, I'm going to share my screen. All right, can everyone see this okay?
Yep.
Yes, we can.
Yes.
First and foremost, I'm honored. Thank you, Black Health Trust, for inviting me here to speak about an issue that affects everyone across all socioeconomic statuses, race. These are things that are issues that I see every day in my office. So a bit about myself. Thank you for the introduction. I graduated from Tufts University School of Dental Medicine in 2011. I went into private practice for roughly about 3 years and began my training with the International Dental Implant Association around 2014. What the International Dental Implant Association is, it is a schooling program that trains doctors on the surgical placement and restoration of dental implants. We also do advanced bone graft surgeries, sinus lifts, rig augmentations, anything that involves rehabilitation of the mouth with implants. I completed my training in 2018 and began teaching part-time with the International Dental Implant Association. I'm in private practice in Washington, D.C. I've been in private practice for a little over 10 years now in D.C. Prior to that, I was in Maryland, and our practice is roughly 35 to 40% surgical. So Replacement of missing teeth is a part of my day-to-day practice. So a couple of the affiliations that I have, I am a member of the American Dental Association and a member of the local DC Dental Society chapter. I am, of course, a member of the National Dental Association and a member of the local chapter, which is the Robert T. Freeman Dental Society. I am a past board member of the Robert T. Freeman Dental Society from 2020 to 2022, and also a past treasurer of the Robert T. Freeman Dental Society. And as I mentioned earlier, I am a member and I teach with the International Dental Implant Association. Last and certainly but not least, I am a proud member of Kappa Alpha Psi Fraternity Incorporated. I'm sure that they are going to be excited to see and hear about the lecture here today. One of the things that are important with my purpose for why I do what I do is giving back. You know, some of you here know my mother. Altruism is a big part of what gets us up out of bed. You know, that ability to have a skill set and to be able to give back with that skill set. This is actually a community service trip I did in the Bahamas. Some of you may remember in 2021, there was a huge hurricane that knocked out Freeport. Remote area medical gave me a call, said, hey, we need, you know, doctors to come down here, dentists to come down here to perform dental care because there was just a large void after the hurricane. So we packed up, went down, and was able to provide healthcare. 3 days, 12-hour days, seeing as many people that needed to be seen. So along the lines with the community service, one of my favorite parts about the International Dental Implant Association is the altruism and giving back that the organization does. So during our training, we have an office, a clinic in Santo Domingo, in which we provide implant surgeries to the population there. So this is at no charge to them. Everything from single implants to full extractions, implants, and restoration with a fixed prosthetic in the mouth is what they have access to. So it is important for me to make sure that, you know, with our skill set, we are giving back to communities abroad. And of course, giving back to communities at home. You have to always take care of home. Here is a oral cancer screening that we did in the DC area. This is with the NBC Channel 4. They hosted a dental screening. It was a health fair throughout, and this is something that I try to make sure that we do yearly. So jumping into the topic of today, most common problems that we see in our dental practice, most of our issues break down into 3 large categories. One is tooth fracture, in which we've actually seen a 70% increase since COVID. Tooth fracture breaks down into essentially 2 categories and then one of a hybrid category. So the first category is being acute trauma. So this is a car accident, a physical altercation, something that causes a tooth to fracture right in that moment. So the second, which is a bit more common, is chronic. So this would be grinding of your teeth, which we'll discuss a little bit later. But there's also a hybrid of the two, which is chronic trauma followed by something acute, which means that, let's say if you chew ice, which is common for people who have iron deficiency, if you chew ice chronically, then eventually one day you're going to chew on ice and it'll break the tooth. So it's not really an acute trauma, it's a chronic issue that's been happening periodically. And as the old saying goes, you have the straw that breaks the camel's back, which causes a tooth to fracture. The second is increase in decay as a result of dental neglect. This is something we'll go into detail about also, but this is something that we do commonly see, especially after COVID. And then last, of course, is breakdown of occlusion due to missing teeth, which again, a large part of what I deal with on my day-to-day practice. So the first thing we talked about is tooth fracture. The most common cause of tooth fracture is grinding, clinically known as bruxism. Grinding is often a response to physical stress. So if you imagine during COVID, I don't know a single person that had less stress during COVID. So that is something that we saw a drastic increase, but grinding will cause the breakdown of the enamel. And this can cause horizontal and vertical fractures in the tooth. If you imagine a big piece of bulletproof glass, if you have a small crack in that bulletproof glass, you might not necessarily feel the effects on the other side of that glass. However, over time, if whatever caused the fracture continues, that fracture can spread throughout until you feel the effects on the other side. Very similar to the dentition, where you might have a small hairline fracture in the tooth. However, that fracture over time, if the trauma continues, it'll spread to the point where it'll reach the other side, and then it will need to be addressed because it'll start to cause discomfort and pain. Bruxism is very hard on the teeth and muscles. It's estimated that when you are grinding your teeth, you are applying 5 to 6 times the force that you would normally apply just eating and chewing. So definitely can cause severe damage if not addressed. When you have fractures, depending on the degree of the fracture, so let's say if it's a small fracture, you may be able to get away with doing a small filling. However, if you have a larger fracture where that fracture has reached the nerve of the tooth, you can begin to have severe irritation. This is the treatment that's indicated is usually a root canal. A root canal we'll discuss a bit later, but it's when you remove the nerve of the tooth while still keeping the tooth intact. So essentially that pain that you're feeling from the air will no longer cause pain. And then after a root canal, you typically put a crown, or otherwise layman's term is a cap on top of the tooth to protect that tooth. If that fracture has spread even further or has caused the tooth to break down completely, then you would need to remove the tooth and then ideally replace the tooth as soon as possible. What's important to recognize, though, is that there is a difference between treating the symptom of bruxism, which is, doing your filling, root canal, or extraction, and the condition of bruxism, which is what is causing you to grind your teeth. If you fix the symptom but don't fix the condition, you will re-break that tooth, which is something that we do commonly see, which is why education is so important when we have the conversations about bruxism. And it's not important to just fix that individual tooth, but recognize what's going on without the entire mouth. There are 2 basic treatment options. Well, there's multiple treatment options for bruxism, but 2, they kind of fall in 2 categories. One, which is the most common, is an occlusal night guard, which is, it looks like a football mouth guard that you place in your mouth. What this does is it deactivates the muscle by keeping the jaw open, so it prevents you from grinding your teeth, especially at night when you sleep. One thing that I found that is increased during COVID is people will wear their night guard throughout the day, because if they're at their computer and they're stressed out, they kind of notice that they're grinding throughout the day. The second is actually Botox. Most people, when they think of Botox, they think of people trying to have smooth skin, but there are some really great clinical applications to Botox. And what Botox does is it's a paralytic agent, and it can go into the masseter or the buccinator muscle, which will partially paralyze the muscle. This actually gives you the ability, it limits your ability to actually clench and grind. So in a lot of ways, it is excellent treatment for treating bruxism. The second topic, which again, we've seen an increase since COVID, is increase of decay as a result of dental neglect. I talked a bit before about the progression of things, which is, if you have a small cavity, that cavity often can be treated with a filling. Filling is just kind of either small composite or which is a clear tooth color one, or a metal filling, although metal fillings are used a lot less. However, if it's neglected, which means you don't get the filling done, that cavity becomes larger. The larger cavity gets, the more it gets to the second layer of the tooth. So on the outside of the tooth, you have the hard layer called enamel. Inside, there's a softer layer called dentin. And then inside of the dentin is where the nerve of the tooth is. So once that decay has reached inside of the dentin, which is that second layer, and then further inside of the nerve of the tooth, a root canal is indicated at that time, because at that time, bacteria has also begun to travel inside of the tooth. And so if that treatment isn't done and that cavity continues, then the tooth will eventually break down, which means you'll have minimal structure in the tooth as a result of decay. And then an extraction, it needs to be done. Extraction is just when you need to remove the tooth. So if you imagine with the progression that happens here, it not only each procedure becomes more invasive, so it's important to make sure you get to the dentist to address those things. Now, money talks. So I often will talk to patients about the financial component of delaying treatment. So most dental insurances will cover fillings almost at 100%. You might pay out of pocket, it may be under $100 for a filling. However, if that decay increases and you need the root canal and crown procedure, it might cost up to $2,500 to get a root canal and a crown. If the root canal is neglected and the tooth breaks down, now if you're having to do an extraction, removal of the tooth and replacing it with the implant, you're up to $4,000, sometimes maybe $5,000 or $6,000, depending on the location of where the implant is. So if you imagine from a couple of $100 to thousands of dollars, if pain is not your motivator, finance should be your motivator to make sure that you get into the dentist, to make sure that you get treatment done. And the third, which is a lot of my concentration in my office, is breakdown to occlusion as a result of missing teeth. If you are missing one or more teeth, it is going to change the way you do a lot of things in your mouth, and it'll drastically affect your ability to eat and chew. So just an example, if you remove a tooth on the lower right of the mouth, the two adjacent teeth will actually begin to shift towards each other to compensate for that space. The jaw exerts a certain amount of pressure, and even with one tooth missing, that pressure has to be distributed amongst less teeth. So it's the body's way of communicating. It brings the teeth in together. So you have two teeth essentially distributing the pressure of three teeth. What also happens subconsciously is that you begin chewing on the opposite side, which causes more strain on those teeth. Now, what often happens is that now a tooth on the opposite side will break down. So let's say the upper left. And now the body now has to compensate for two missing teeth. Well, eventually what happens is that you will either consciously or subconsciously have to change the way you eat. You begin to eat more with your anterior teeth, the teeth in the front, and you have more pressure on less teeth. This is often seen with patients where if they have teeth removed, their teeth will begin to spread out and push out buccally. So if you ever heard the term like jack-o'-lantern teeth, what that comes from is essentially people are missing teeth in the back, so teeth are shifting out in the front. Now, as this problem continues, people get into what's called I call it the extraction game. I got a problem here, pull this tooth here, pull this tooth here, pull this tooth here. And eventually you only have the front tooth remaining, and people say, whoa, 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 I don't want to pull my front teeth. Well, if you've removed all your back teeth, you don't have anything to support. Your posterior teeth, which are the teeth in the back, are designed for mastication, your ability to eat and chew. If you're missing those teeth, you've been forced to use your anterior teeth, the teeth in the front, to chew. So the teeth have spread out to create more surface area to chew. Common symptoms will happen. You'll see food coming out of your mouth if you have to chew with the front. Also, you can suffer from indigestion. You're not able to break down your food as much, which means you're swallowing bigger chunks of food. So with each tooth missing, problems become compounded. This is a patient of mine, which does have a happy story, which I'll share towards the end of the lecture. But he essentially was playing the extraction game, and it got to a point where he only had 4 teeth he was able to eat on. And all those teeth were mobile. They were moving back and forth, so he's unable to break down any type of food. So he came to my office, and he needed to address this fully. So signs of these dental issues. Nearly 40 million Americans are either missing all of one arch, which means they're either missing all their top teeth or all their bottom teeth or all their teeth in general. Nearly 178 million people in the United States are missing at least one tooth. And the prediction is that over the next 15 years, that will go to 200 million individuals. As we talked about the various reasons for the tooth loss, gum disease, decay, periodontal disease, conditions such as cancer, which does affect the bone, diabetes, which is linked to periodontal disease, which is the loss of the bone around the tooth. All these things can result in tooth loss. And it's very important to understand that edentulous affects the most vulnerable of our population, which is the aging and the economically disadvantaged, which we'll touch on in a little bit. But as you imagine, as you get older, you begin to lose teeth because your bone becomes weaker. And obviously, if you're economically disadvantaged, if you're removing a tooth, you may not have the funds to replace that tooth, which creates the problem that we just discussed. In the geriatric population, the edentulous individual, it's a 2-to-1 ratio. So that means that for every 3 geriatric patients, 2 will be edentulous in some form. 23 million Americans have no teeth, and about 12 million Americans are missing at least one arch. So they're either missing all their top teeth or all their bottom teeth. 90% of the people who are edentulous, their option for replacing missing teeth are dentures, traditional dentures that are held in by just suction. That's the retention that's there. I always like to give a frame of reference for dentures. So if you think about if you have all your teeth in there healthy and that gives you 100% stability to eat or chew, and you have 0 teeth in your mouth, which gives you 0% ability to eat or chew, dentures only take you to about 20%. So this is very important when it comes to understanding patients who are getting dentures and where they have the complications, because if you're trying to eat 90% things on 20% dentures, a lot of times they will have frustration and lack of success with understanding how to use dentures. So implants provide a lot more stability. Depending on the type of implants that you have, you can get up to 90%. Stability, which is not quite 100%, but gets you really, really close to the point where you can enjoy food and things like that. Consequences of missing teeth, of course, can cause significant nutritional changes. So things like carrots, it's a lot of pressure and it's a lot of nutrients, so you're not able to eat it, break those down without teeth. So the only way to really break it down is to soften the carrot. So boiling it, which you lose a lot of nutrients with it. Fat is something that is very easy to swallow and digest. French fries are delicious. Whether you have teeth or no teeth, you can break down a French fry. So another common thing that we see is obesity. Starches are oftentimes a lot easier to break down because of that. So conditions such as diabetes can also happen because certain things such as pastries have increased sugar. A lot of things that are soft and sweet will have a lot of sugar. So people will tend to kind of drift towards those things because 1, they're easier to eat, and 2, they enjoy eating them more. Of course, coronary artery disease, some forms of cancer can be seen as a result of missing teeth and essentially having poor digestion and things like that. So what is the solution? We've obviously discussed a huge problem, and the solution breaks down essentially into 2 categories. The first and the best option is prevention, and this is something that is definitely an issue in this country, but also a global issue. But the first and best option is prevention, which we'll discuss prevention, and the second is treatment. Depending on the breakdown of the dentition will determine how evasive, how comprehensive that treatment is. It also determine a cost, time frame, and things of that nature. So prevention. These are some rules that some basic dental rules. You should be seeing the dentist twice a year for annual exams and cleanings. It's great to do this because you can tend to catch problems while they're small. If you imagine if you're going every 6 months, there's a higher chance that a cavity will be seen, it will be caught, it will be treated sometimes right then and there on that visit. In terms of our home care, we should be brushing our teeth twice a day, flossing twice a day, rinsing twice a day. Technology has been amazing. So there are some amazing tools that will help with brushing. An electric toothbrush is a must. It's just with where we are now, there is no reason for a manual toothbrush. What an electric toothbrush will do is going to just be far superior. And fortunately, the cost on them have gone down to the point where they are affordable. So I would highly encourage an electric toothbrush. Flossing has, there are a lot of technological advances with it. A water pick has become kind of the most popular way. I do find that there's nothing that replaces the string floss. It's a great way to remove food from out in between the teeth. I think a water pick is a great complementary tool for flossing. I believe people should just use both. And if you imagine, you think about the cost of the water pick or the cost of the electric toothbrush, one filling will cover that cost. So you want to, it's really, even though it's a little bit expensive on the front end, it'll save you a lot of money on the back end. And then rinsing twice a day with the mouthwash. I personally prefer Listerine with the alcohol in it. But as long as you're using some form of a mouthwash, Listerine, Colgate, Crest, something to help kill off any bacteria in the mouth and also remove any remaining small particles of food. Another important part of prevention is understanding the impacts of certain foods and habits. Negative effects of smoking is very important. This is a big component of my practice. Smoking, there's no real way around masking the negative effects of smoking on the dentition. You will lose bone. You will have severe decay because it lowers the pH in the mouth. It makes the mouth more acidic, which allows bacteria to fester. In DC, marijuana is legal. So probably the number one question I get every day, I say, do you smoke? And they say, you mean cigarettes? It does not matter what you're smoking, whether it's cigarettes or marijuana or tea bags. If anything that has a carcinogenic burn, which means you're lighting it on fire and bringing it into your mouth, is going to cause damage to your teeth, to your gums, and to your alveolar bone, which holds the teeth in. Understanding the negative effects of high sugar foods and sweets. Cupcakes are delicious, but enjoying a cupcake every single day will have negative effects on the dentition. So it does not mean that you have to give up, sweets altogether. But I often like to compare sweets to a vacation. You can't vacation every day. Sweets should be something where once or twice a week, something along those lines. This will allow you to still get your sweet fix, but doesn't cause negative effects to the dentition. So the mouth is pretty resilient, which means that if you have sugary foods or if you drink coffee with sugar in it, it will lower the pH of increase the pH of the mouth, so the mouth will become very acidic. However, if you're drinking water afterwards, the pH balance will balance back out so that it doesn't create an environment that can cause rapid decay. However, if you're drinking coffee all day, having candy all day, the mouth doesn't get a chance to balance out the pH of it. So, and then lastly, negative effects of hard foods. So, biting into hard candies, now and later's, Jolly Ranchers, things like that. Hard nuts like almonds. So if you are repeatedly biting into almonds all day, eventually this can cause a lot of wear and tear on the teeth. Something that I did not discover, growing up in Boston, we didn't have this issue, but this is a huge issue here, which is like crab legs. You have a bit of the crab leg, you're trying to get the remaining of the crab leg out, you're biting into the crab leg, you can break your teeth. The first time that happened here, I was like, oh, that's a bizarre story. 10 years here, I can say that at least once a week, I have a crab leg injury or somebody's trying to bite into a crab leg and they end up breaking a tooth. So just understanding the negative effects of eating hard candies, hard foods, things like that. Now, there's often a lot of roadblocks with prevention, which I did want to discuss today. Some of the first is phobias. There is fear of procedures, which the resolution for fear of procedures, we try to use education in my office. So just an example that I see every single day. which is if I come in and I see a patient has a large cavity and I say, hey, you need a root canal. If their response is, oh man, that's going to be expensive, or oh man, I don't have time for this today, but okay, I got to get the root canal. I know they've had a root canal before, but if they start like holding their chair, praying, calling their mother, calling their grandmother, and they haven't called their grandmother in years, what that tells me is that they're unfamiliar with the procedure, and their fear is the fear of the unknown, that they have listened to other people's kind of half stories about what a root canal is, and that has created a narrative in their mind that a root canal is painful. Root canal is a routine treatment, and I would say most of my patients, they fall asleep when we do a root canal. So it is, it is a routine component. But what happens is that people tend to tell horror stories. Almost nobody tells their good experience at the doctor because they don't feel it's entertaining. Telling the negative experience is what's entertaining to a lot of people. And they tend to have what's called revisionist history, where they leave out key components. They started a root canal, but they didn't return to finish the root canal. They didn't take their antibiotics and they got a reinfection. They didn't go back to get their crown and the tooth fractured. They tend to kind of leave these components out. And then what happens is you kind of get, I call them like these barbershop stories, where they're just kind of these half truths of their experience. But often, every day when I'm seeing, every day we do root canals, buildups, crowns on patients, and they tend to have very minimal complications. So again, going back to the solution for that, we really try to utilize education for that. The second is a fear of needles. And this is another, fascinating one. At least once a day, I will have somebody in my office tattooed head to toe saying that they are scared about needles. And I didn't quite understand it, other than the fact that it exists as it's a psychological phobia. Some things can't really be explained. So what I tend to do with fear of receiving local anesthesia is I just talk them through the best way to go about it. Something that's very interesting, when we have to do emergency treatment on minors, the consent goes through the parents. So I don't even tell the kids about the needle, and a lot of times they don't feel the needle, so I don't tell them. I just say, I'm shaking your lip. I numb them before they know it, they're numb. And then it's interesting because later they're waiting for it, and it's like, no, there's no, you're numb already. So for adults, I can't just go numbing them without consent. So you have to have that conversation with them. But like I said, what I do is I talk them through it, relax, breathe in and out through your nose. Oxygen flowing will really help with the local anesthesia. And typically, like I said, we see a lot of patients a day. We don't have any screaming. We don't have any kind of theatrics in our office. And so I find that talking them through that really does help. Another roadblock is cost of dental work. Dentistry is expensive, and most insurances do not cover dental treatment, especially advanced things. So procedures such as root canal or implants are often not covered. It's interesting that when we travel outside of the country, the access to healthcare is the reason why we're traveling. There is physically not a dental provider around. However, locally, a lot of times you have dental providers that are around, but there is no access, because if financially you cannot afford to see that dentist, then you do not have access to that office. So it's a different type of disparity, and that is a big topic. That is another lecture for a different day, but this is certainly a problem that we do face in this country. That really does need to be addressed. Otherwise, dentistry will keep becoming more expensive, more costly, and more evasive. So one of the things that are important is to understand that dentistry is very different than other aspects of healthcare. So certain aspects of healthcare have the benefit of time. An example would be if you sprain your ankle, right? Let's say you don't go to the hospital, you go home, you rest, you place ice on your ankle. In a couple of weeks, your ankle will heal. It might get back to 100%, if not close to 100%. If you have a cold, if you don't go to the hospital, you stay home, you have medicine, you rest, in a week or so, you're kind of back to normal and your body has fought off that infection. Dentistry is not like that. A cavity will not go away kind of with rest. A cavity will continue to progress. So I often compare dentistry to like a leaky roof. If you have a small leak in your roof, so when it rains, you have a leak, When the rain stops, it goes away. You might have the appearance that everything is okay, but the leak is still there. When rain comes back, that leak gets a little bit bigger over time. And then eventually you'll have a roof that caves in or falls apart. A dentistry is very comparable to that in the sense that if you have a small cavity and it's not addressed, eventually that tooth will break down. And so not only the treatment becomes more invasive, but again, as I talked about before, the cost will go up. So one of the biggest things that I encourage with people is get to the dentist to get a game plan. Even if you cannot afford that game plan or that game plan will have to change consistently, going every 6 months to at least get your exam, get your cleaning if that's something that you're able to get, and come up with a game plan to address an issue. Because sitting at home, the problem is not going to go away. And then the second option, of course, is treatment. So treatment kind of breaks down into 3 categories. The first, of course, being routine treatment. This is going in every 6 months for your cleanings. This removes plaque and calculus buildup from your teeth. That's the yellow buildup, sticky film that you see on your teeth. The second, of course, is fillings for small cavities that are still in the enamel, which is the hard surface, or in a small part of the dentin. Excuse me. So this is the area that we would like everybody to be in when it comes to dental treatment. The second is emergency treatment. So this a big example of what I see day to day is root canal treatment for cavities that have reached inside of the dentin. So someone comes in, they're in tooth pain. We do the root canal, they leave out with no pain. Root canal treatment is it's an excellent treatment option just because it really does put you right back on track the same day. If you imagine, there are very few aspects in healthcare where you can walk in and you think, man, life is over, and you walk out and you're just, you're right back to being out of pain, eating, doing all the necessary things that you do throughout your day. Of course, after root canal, you want to make sure you get a crown on the tooth to protect it. But in terms of just addressing the acute pain that you're feeling at that time, root canal is a great option. And then the second emergency treatment that we often see are extractions. So if a tooth is fractured or somebody has gross clinical decay and minimal tooth structure remaining, these typically result in extraction. For the non-healthcare professionals, gross clinical decay is a clinical term, so it doesn't mean gross as in ew, it means gross as in extensive. So, but essentially, if you have extensive decay in a tooth to the point where that tooth needs to be removed, at the time of the extraction, it is ideal to either replace the missing tooth that day with an implant, or plan to get an implant in that extraction site as soon as possible. So in a lot of cases, when we remove a tooth, we will try to place an implant in that same day, or we will plan for 3 months down the line to place the implant in once that alveolar bone has healed from the extraction site. So, and then third, which is something that we do a lot in our office, is full dental rehabilitation. This also breaks down into 2 categories. One is when you're doing extensive prosthetic work around teeth that are still present in the mouth. So for example, you are missing some teeth, but you have teeth that can be repaired and can be restored. So a lot of times we are repairing teeth that are fractured with crowns or bridges. We are also replacing missing teeth with implants, removable partial dentures, so that the end product will be, excuse me, is that mine? That's not mine, okay. So that the end product will result with you having full function from your back teeth all the way to the front. The second category is extractions of all the remaining teeth and replacing the teeth options. And which breaks down into essentially 2 options. One is the traditional denture, which is held in by suction. And then the second is the surgical placement and restoration with implants. We talked a bit before about the kind of stability percentages. So with a complete denture, as we said before, you're looking at stability of roughly around 20%. Whereas with implants, you can get up to 85, 90% of where you were when you were missing all your teeth. So just to discuss a few small cases that we have, this is a patient who had unfortunately gotten into a physical altercation and he fractured his front tooth. Now, the tooth was endodontically treated. It had a root canal in the crown, so he was not experiencing pain. What we did was we removed the tooth and we placed a implant in at the same time. And we actually fabricated a temp chair side. So once the tooth was taken out, we utilized that broken crown to make a temporary crown so that he walked in with a broken tooth and walked out with a temporary crown. Outside of clinical experts, nobody would know the difference. And this is an excellent treatment option that that you have with implant dentistry. However, the downside is that it is expensive. So so it is one of those things where this can cost in the high 4 figures, low 5 figures to have this all done same day for just one tooth alone. So again, the advancements in dentistry, specifically implant dentistry, have been great. You can imagine this person came in, he was very different emotionally coming in than he was going out. So it is very humbling to be able to be in a position to do these things. And it's one of probably the most pleasurable part of my job. What a lot of people don't really think about is the improvement of the quality of life with full rehabilitation. So this is a full rehabilitation. One of my patients, very sweet patient, she had a partial denture that was made some time ago when she was young. She was a teenager when it had it. If you notice, she does not wear that partial denture very much. And the reason why I can tell that she doesn't wear it is because the front tooth is what's called hyperoccluded. So we talked a bit before how teeth, when you lose them, they push down and push out. As you can see, she's been forced to use that front tooth to chew, which is why it is positioned like this. Even the canine that is to the right of the photo, same thing, it's pushed down and she's had to use that to kind of break food. So she kind of breaks food with the side of the mouth and uses the front mouth to chew. So a complete breakdown of the dentition. So what we did here is we did comprehensive care. We removed the teeth and actually replaced everything with a full maxillary prosthetic for the top of the mouth. She actually has full function. She's able to eat on the back teeth, chew. She can incise food, bite into things, and she is through the moon. I believe she was 23, 24 years old in the picture. So you can imagine the amazing increase in quality of life with this. Even the smile is different. You look, we always tell patients smile, so we have a profile. Look at the difference in the smile from the first picture to the next one. You can see the confidence in that picture. Since then, she's went back to school. I think she got a new boyfriend. I don't know what the teeth was related to the old boyfriend, but she said, I got a new boyfriend now. So, I was really happy to kind of be a part of that. And when you do something like that, they'll never forget you. That's a complete change in their quality of life. I told you before, there is, there's a happy ending to the story for that one patient. This was a patient of mine where we ended up doing full rehabilitation for him. This is an implant hybrid denture. Now, this appointment did take some time to do, but from when he first came in, which is the condition here, where he's only able to chew on 3 teeth, to when he left, where he had full dentition, this gave him 90% stability. So if you imagine he hadn't had that in decades, being able to eat, chew, smile. One thing that's very important, and I do talk to the patients, they'll always ask me, well, what can I eat? And I say, please don't eat the things that cause the teeth to break in the first place. So that is a common issue that we see. So if you broke your teeth chewing ice and we repair the tooth, don't go back to chew ice. If you broke the teeth eating hard candies and we repair it, don't go back to eating hard candies. If it can break a natural tooth, it can break a crown, it can break an implant. So you want to kind of avoid those. This here is just some office info. I'll have it up there. So if anybody had any questions, and a bit about our website, if you kind of see a bit of the work that we do. Does anybody have any questions? This is actually a photo that we had took at that same health fair. My wife was there with our son and his best friend Jackson. It was hosted by the NBC Today show. So they had this little cute area. But anyway, does anybody have any questions or anything about the information presented?
Before they ask questions, first, I want to thank you so much for your astute lecture. I learned a lot. I'm a certified dental chicken. I attended another dental lecture a few years ago, and the dentist said what I think was a good piece of advice: only floss the teeth that you want to keep. So, but just a little bit, I deal a lot with cardiovascular medicine. Is there a major effect of oral health and dentition on cardiovascular medicine and effects down the line with people?
So in terms of the specifics of cardiovascular, I don't know the exact specific direct correlation, but what I will say is that the oral cavity talks to us. It tends to be the gateway for a lot of health conditions. So, for example, if somebody has severe periodontal disease, a lot of times it is linked to diabetes. If we see missing teeth in the mouth, it is often linked to they often will ask, hey, do you have indigestion? Because they're unable to break down food. So there, like I said, there are just a lot of clinical implication for it, but I don't know the specific ones. I definitely can research them and get back to you with that question.
Thank you so much. Dr. Neighbor-Stevens? Is Dr. Neighbor-Stevens unmuted?
In the interest of time, I'm going to start with some of the questions. I'm going to start with questions in chat, and hopefully we can get to all of them. The question was, why do teeth turn gray as you age?
Interesting. So teeth don't turn gray when you age. Teeth turn gray when they're necrotic. So as you get older, teeth turning yellow is a normal transition of color. And this has to do with just kind of increased staining over the years. So if you're an increased coffee drinker, red wine drinker, if you're a smoker, that staining will get into the enamel. And if you're not getting your proper cleaning and care, eventually it'll become something that's very hard to remove. However, gray teeth are a sign of necrotic teeth. So if a nerve dies inside of a tooth, the tooth will begin to turn gray. Something that's very fascinating, when a root canal is done, a root canal is essentially a dead tooth. You're able to use it functionally, but the blood flow, the nerve, the artery, everything that makes that tooth alive is dead, so it becomes very brittle. So you may have all seen that person where you smile and they see that one gray tooth. That typically one or two things have happened. Either the tooth has had some type of trauma in it, which as a result, it's died, which turns gray, or the tooth has been root canaled and they have not gotten their crown, which causes it to turn gray. Excellent question, though.
Thank you. Dr. Walks and Dr. Hines, chime in as you will.
Dr. Coombs, this is Dr. Walks. Thank you so much, sir, for really a great lecture. I remember years ago working with the California Dental Foundation to try to get fluoride into some communities as a part of the preventive part. I go to my dentist twice a year. I get my teeth cleaned twice a year. I brush and I floss every day, and the dentist still scares me. So, so for someone like me who kind of grits and goes anyway, what do we do about this sort of, because it's not just me, this sort of community-wide concern about going to the dentist? Is this a matter of getting more into schools with young kids and don't be afraid of the dentist? Is this more of making the dentist more available from a preventive standpoint? How do we get our community in particular? And let me just say this. I remember a story years ago about a young boy that had a bad dental infection, didn't get help, and it tracked back and he actually died. So
Delonte
these
Diver.
are not
Yes.
inconsequential things. How do we get folks to go to the dentist?
So The key in my practice, and this is something that is anecdotal, so I will need to, I can't give you numbers on this, but what I do find is when I get to the source of the problem, um, dentistry has changed much like the United States has changed. So if we just go back 50 years and you think about what was the experience as an African American receiving dental care, your options were limited. The idea of having a provider that not only looked like you, but genuinely cared about your long-term effects of the dental treatment getting done was very minimal. The reason why most of my elderly patients had most of their teeth removed is because they would tell the story, hey, I went into a clinic. He said, what tooth hurts? They point to the tooth, they pull the tooth. And eventually what happens is that that phobia gets passed down. That phobia is not with my younger patients, which is interestingly enough. If there is a phobia with a younger patient who hasn't had a negative experience, I tend to track it back, and it'll either go back to the mom or the grandmother. And they will often tell some story in their childhood, and they have decided to relay that information to their child. So I really do think that it's getting to the origin of where the fear comes from. I do find now, which is interesting, it's, I've been doing dentistry roughly around 15 years. I find that with the patients where their parents have good experiences with me, where, 10 years ago, I've done rehabilitation on them, their kids have no phobia of it. Granted, I don't like that I have to do fillings or root canals on these kids, but if I'm doing a root canal, the roadblock isn't, I'm afraid of the dentist. It's just more, okay, how do we get them to stop eating candy? So, I really do think it's understanding where the phobia comes from and also understanding the importance of it. One of the biggest conversations that I have is, the price of reconstruction with implants is very, very expensive. It can range from $35,000 to $50,000. And, that's a sticker shock price. That's not something. So the way I frame it when people talk about it, I was like, look, $50,000 is a lot of money, so you have two options. Do you want to buy a car? Do you want to eat steak? Because, buying a $50,000 car, nobody thinks anything of that. I mean, you can have a job that makes $50,000 a year and drive a $50,000 car and nobody thinks anything of it, but you have to know what is valuable to you. And once you frame it in that way, a lot of times people change their thought process on the dentist. They're like, oh, I would like to have steak, especially ones who have been missing teeth. Oh, excuse me. Especially those who have been missing teeth for some time and they actually have recognized, hey, I miss doing X. I used to be able to eat a sandwich and not think about it. And so that goes to their mind. And oftentimes, if they do have the means, they do end up going with that dental route.
Very good. Thank you. Dr. Hines?
So thank you again, Dr. Coombs. This was a great talk. I have a bunch of questions. I'm out of the crab leg camp and was definitely raised in that group that's like, if you need crackers, then you're being a wimp about it. But two questions. One of the things I thought that you said was, if you know you have dental issues, but you're worried about the cost, get a plan. And so my first question is, are there questions that are appropriate for your general dentist versus dental specialist? Because sometimes asking the wrong person can not necessarily lead you to getting the right advice. And then my second question is around, there's a lot of these kind of franchise, we'll do same day, full mouth restoration places that are popping up. Is that something, are there any concerns there? Any particular things we should be looking out for and with those kinds of things?
So really two amazing questions. Let me tackle the first one. When everybody is going to have a bias on some level, you take the same x-ray and you go to an endodontist, he's going to say, oh, you need to root canal that. You go to an oral surgeon, he says, oh, you need to pull that. You go to a periodontist, they say, you may need to treat the gums. So it is important to recognize your bias, which is the key for providers to continue to do education. So I'm in a very unique niche in the sense that I have done about 5 years of training for implant placement and restoration, but I'm also a general dentist. So I see a underserved population. I treat a lot of beneficiaries of DC Medicaid. So I kind of have to be able to know how to do a root canal or know how to do an extraction almost at a whim. So a lot of times I am presenting my scenarios to the patient where I'll say, okay, these are your three options. You can do a root canal on this tooth, and that will have this type of success rate traditionally. Extraction and implant, which will have this type of success rate, and no treatment because you have patient autonomy, which obviously has no success rate. And I will say, this is what I feel is the best option at that time, but I will never offer you a clinically unacceptable option. So every dental treatment has its pros and cons. A lot of times, with implant dentistry, the biggest con, it typically is cost. Implants have a 98% success rate. So an implant is a great option. Also, the downside is you lose your natural tooth. Root canals, they have a slightly less success rate. I think it's 85 or 90%. Now, all of these things are based off patient compliance. So we typically will factor that into it. Hey, there's the term, be good or be good at it. So if you're not going to be a good patient, then you need to know enough to say, hey, doc, I'm not going to, do this. So we might as well go with this treatment option. So that's where coming up with a plan is so important. I think more important than like getting a bunch of second opinions is you need to have a provider that you trust, because there's a lot of ways to get to the end of dental treatment. You talk to 10 doctors might give you different treatment plans, but if each doctor can see you from the beginning of that treatment plan to the end of that treatment plan, then that's what's more important than which option that you go with. You can find doubt in any treatment plan, but that's what's very important. The second part of your question is a very complicated question. I'll first talk about just kind of the clinical component. So if somebody is surgically trained, they have the right tools, the right laboratory, they are doing things ethically, they're making sure they are seeing patients that are healthy enough for treatment, and they're doing same-day dentistry, there's no issue with that. I actually think that's an excellent option to have, although that's very, very expensive, because not only, implants are, if you remove a tooth, you're pretty much, the out-of-pocket cost for a doctor is essentially cleaning the instruments. Excuse me. If you're doing implant dentistry, there are a lot of things that are very, very expensive. So you can't even really offer it for cheap if you wanted to. So if I'm going out of the country to remove teeth, that's really at no cost to me. But if I'm placing an implant in, the implant alone can cost up to $500. So that doesn't include the labor, that doesn't include bone graft, so, you're going to pay a lot of money for that same day dentistry. Now, the issue that I do take, which is a bit of a complicated issue, is when you have what's called corporate dentistry, or DSOs. This is when private equity firms are getting into it. And which means that if you have these offices that are popping up, if the basis behind that office is a private equity firm, the goal of a private equity firm is to buy low, sell high. The only goal of private equity is profit. So that becomes very dangerous, because how do you ensure profit? You have to see where you can cut costs. And that becomes a very, very dangerous game. It doesn't mean that every DSO is bad or every private equity firm is unethical, but it is something where if you see 10 pop up, they have to pay the staff, they have to buy material, and they have shareholders that they have to answer to. So that becomes it becomes a gray area. And again, this is a big topic for another day, but I just kind of wanted to cover. I think there's no problem with the actual concept of same-day dentistry, but you need the patient has to be the top priority with the same-day dentistry. As long as the patient is the top priority, I think it's an excellent option. So I'm sorry, I hope that answered your question.
That was an excellent answer.
I could do a whole lecture on that.
And what I heard is choose wisely. Yeah. Mm-hmm. And
Yes.
you said people who can see you through from the beginning to the end. I got it. Yep.
So,
Dr. Coombs, I thank you for your time today. It's been very informative. But before you go, you talked about being the treasurer of the Medical Society named for a Robert T. Freeman. Wonder if you could tell us a moment about this pioneer. And we hear a lot about Black physicians from time that started, but we haven't heard much about Black dentists. Can you just give us a moment on him, and then we'll ask you for final words?
I will be transparent. I know the significance of Robert T. Freeman. I know his significance at Howard. But I want to speak on things I'm an expert on. So Robert T. Freeman is the Dental Society does have a vast history, but I don't want to. I want to make sure I do my research and come back. I did not prepare for that question.
Okay, well, thank you. So are there any final questions we have in the chat, doctors?
We got a
Dr.
bunch that
yeah.
I don't think we're going to have an opportunity to respond to today. But what that tells me is, Dr. Coombs, we need you to come back because we have a bunch of questions for you.
Yes.
Well, I'm very honored. Thank you so much for having me. This was great. My wife was awesome for letting me use her office. So this is a privilege. I'm usually not allowed in here.
Thank you so much. Dr. Hines, any final thoughts?
Again, just wanted to thank you for an excellent presentation. I learned a lot too, right? And things that I've seen over the years now have a different significance. So thank you.
Dr. Walks?
I like Dr. Nabors-Stevens. I think that we have seriously a lot of very good questions that we have not had a chance to get to today. Some of the, particularly around some of the health implications of poor dentition and all of that, and basic stuff like how long should you brush. There are a plethora of very important things. And as Dr. Maxey said, we haven't had historically that access to dental expertise. So Dr. Coombs, thank you so much, man. And we really would like you to come back.
Anytime, just let me know.
Dr. Nabors-Stevens?
Well, my final thoughts for today are that, yes, we are very grateful for your time and expertise today and look forward to tapping into it. And you focused on adults, and this is my pediatric bias, people kind of at the end of the road. When you come back the next time, maybe we can talk about some preventive things as well.
Absolutely.
I'm going to make a special plea to unmute Dr. Alice Coombs. She's a member of our advisory board for a comment. Dr. Alice Coombs. Simon, can you unmute?
I don't know if we're in double.
You're on
You're
two.
getting a
Yes.
big echo.
Yes, hi. I don't know if you can hear me right now, but I'm just so proud of Albie. The reason why he went into dentistry are numerous, but one of the things that happened was he read an article that I gave him about Diamant Dwyer back when he was just a young lad. I don't know if you were like first year of college or last year of high school, but it was about a young 12-year-old African-American kid whose mother could not find a dentist. He had a tooth abscess, which went to his brain, and he had a repeat brain abscess, a second one, and he died. The title of the story is For Want of a Dentist on the Washington Post. And I would encourage anyone who has a young lad who might be interested in dentistry to read that, because that made so much difference. And Albie got the fire in his belly. Mommy, I want to work in DC for people who don't have any choices. And he actually specifically said, I'm going to take care of Medicaid patients. And that's what he's been doing for 10 years. So I just said, it is really an emotional story, but he is committed to that. And I go to him as his mother, and I walk in his office, and he has some different type patients. He has some that are, really professional. And then he has some that walk in that office. And I'm like, Albert, you got to have the fire in your belly to do what you do. So I'm proud of you, Albie.
Thanks, Paul.
Thank you, Dr. Coombs. I asked him if you were his sister. I did not know he was your son. But good. Dr. Walsh, you have to give me less stories in. I'm going to fly to DC and see Dr. Coombs for my dental health.
You got it.
Okay. Thank you, Simon. Thank you, everybody, for your participation today. And we'll see you next Sunday. Have a great, great Sunday afternoon. Thank you.
Thanks, everyone.
Bye, everybody.